Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
All right, here we are at our next podcast for Advanced Vision Care, and I'm John Berdahl. I'm an ophthalmologist in Sioux Falls, South Dakota, do cataract, cornea, refractive, and glaucoma. Today we're talking about glaucoma, and we have got some high-test, great people that take care of all aspects of glaucoma and from different perspectives. So, Spencer, would you give a quick intro?
Yeah, so I'm Spencer Morton. I'm a cataract and glaucoma surgeon in our South Sioux City, Nebraska location.
Great. Justin?
Yeah, I'm Justin Schweitzer. I'm an optometrist, work alongside John here in Sioux Falls.
And Lori.
Lori Provencher. I'm a cataract and glaucoma surgeon at the Omaha location.
Okay, so just to give a little context, I kind of was fellowship trained from cornea to glaucoma. Spencer, comprehensive, busy ophthalmologist, taking care of whatever comes his way. Justin, one of the real leaders in glaucoma in the entire field of optometry. And Lori, hardcore glaucoma trained, real glaucoma fellowship, throw me at the toughest stuff. So you will see that we all defer to her, not just because of her smarts, but because those biceps are no joke.
I was gonna say, she not only intellectually flexed on us, but like physically flexed on us.
Yeah. So I'll try and keep us from getting dominated too much the first 15 minutes or so, if I can hold her off that long, and after that she'll just take control. So guys, we're talking about modern day glaucoma care. And Spencer, you've been in practice how many years?
6 years. 4 years with BTV.
Justin?
18,
Dude.
like that. 06.
Yeah, and I'm at 15. And Lori?
6.
Okay, so the first question that I want to ask us all is, how has glaucoma changed since you came out of your training? And so we'll start with the most recent. We'll start with Lori, go Spencer, Justin, then Justin. Since Justin, you're the oldest practicing eye doctor on this call. All right, Lori.
Well, it's changed dramatically. I'd say we have drug delivery now that we didn't have when I went through training. SLT has moved into first line, and we'll talk about that later. But a whole new set of MIGS options, and now a major shift in how we treat glaucoma overall is kind of occurring.
Great, Spencer.
Yeah, I think I would agree with Lori to some extent, and I think some of it was also a byproduct of where I trained. I trained at a fairly traditional residency where, if you had glaucoma, you were getting eye drops and a tube or a trab if it got out of control. There wasn't a lot of MIGS or drug delivery, and there was a lot of hardcore glaucoma that walked through the door. So I think the biggest thing that kind of hit me in private practice was the options that we have with SLT laser, drug delivery, some safer surgeries that are much less invasive than a tube or a trab, and kind of just the continually emerging field of other options, and letting you tailor what you like and feel most comfortable using.
So for me, the thing that's changed the most is MIGS, SLT, and maybe my mindset. Maybe it's me that's changed the most, because I take into account way more the convenience and quality of life of the patient and less their IOP, and try to think about it from the perspective simply of what would I want if it was my eye. And I think that that's the right approach to take, because we've got so many more options than we had 15 years ago when I came out of training. Justin, how's it changed for you?
Similar to, I'm not going to have a lot to add here from what you three said. It used to be meds. And, my mindset definitely has changed on how I treat patients. But, piggybacking on what you said, John, I think I care a lot more now about the ocular surface in glaucoma patients where I didn't even care about it probably 10, 15 years ago, especially when I got out of school.
Ocular surface.
And so caring about that ocular surface matters as much as I care about the ocular surface in a patient that's going to get a advanced implant or undergoing refractive, LASIK, PRK, whatever it may be, making sure that that surface is healthy and happy, because that's the quality of life piece that matters too.
And the
So,
other thing is we didn't even have the chance to, I mean, it's not like we didn't care. Obviously, we always cared, right? But now we have better options so that we can hone in on those things like surface and quality of life.
Yeah. And 18 years ago when Justin was coming in, Carpacol was pretty much all that was available. And so that was pretty tough on the ocular surface back in those days, Justin. Okay, so let's make this provocative and have different questions. My question, I'm going to start with Justin. What percentage of patients that come in untreated with early glaucoma, we're going to call it actual glaucoma, not just ocular hypertension, pressure at 23. What percentage should get an SLT?
100% should get it.
Okay. Spencer?
I would say 100% of the open angle ones that that are a good candidate would.
We got a splitter. We got 100% of people that are a good candidate should get it. That is a cop-out answer.
You said per people with glaucoma. If their angle's closed, I'm not doing SLT.
Okay, fair enough. Open angle glaucoma.
I would say 100% should be offered it.
Okay. How many should get it?
100%.
Okay. I'm coming back to you in a second. Lori?
Okay.
So if the ankle's open and you think that SLT is a reasonable option at lowering their pressure to their target. Somebody comes in with a pressure of 40 and severe disease, you probably should not do SLT. But I think if they're within
mild open angle glaucoma.
Yeah. Mild, moderate, open angle, or ocular hypertensive, high risk, SLT, 100% of the time.
100% of the time. And so, Spencer, these guys said 100% of the time, kind of really glaucoma focused practice. You said 100% should be offered it.
Mm-hmm.
So let's poke at that distinction a little bit. Why do you say that?
Because like you asked in the beginning, if it were my eye, what would I want? And what do I feel is best? I think SLT. But I do think, and I don't know if it's just the community where I practice, but it feels, that was one of the biggest things that slapped me in the face when I got here. It was that SLT is probably the most underutilized tool in the glaucoma tool chest in this region. And I think that there are patients who hear laser, and even when I tell them, hey, it's actually really safe, it's been around for a long time, it's not going to hurt, it's just as effective as a drop, and I think it'll actually make your quality of life better, and it's more cost conscious. Still, there are people that say, I don't want that. And so, maybe I was, like you said, splitting a little bit. I think that preferably 100% of those patients would have an SLT to start off, but not everybody actually wants it.
Do you feel like, as a comprehensive ophthalmologist, you may be less convicted that SLT is the first line treatment, that than, say, a glaucoma specialist is? Because that's I'll just say that's my thesis.
No.
My thesis is that Lori sees big bad glaucoma at the end. And so at the front, she's like, no, you're getting an SLT.
No, I don't think
it's the right thing for you.
I don't think that's true. I think that we all have the same task, which is to enhance and protect vision. And if there's something that I think is going to protect vision, I sure would hope that I would press on it just as hard as Lori would.
Okay, one more press I'm going to put on you then. Are you going to tell them to do it, or are you going to offer it to them?
Yeah, I tell people, if it were balloons, that's cool. I tell people, if it were me, I would if it were me, I would for sure do it in my own eye. And that's what I would recommend for you.
Okay. So if I was to say the one thing that can change the glaucoma landscape the most for the better, it would be doing SLT as first line on basically everybody that we can. And I believe that we are the ones that create the dynamic in the communities that we're at. And so that's, that's kind of on us to say, this is the standard of how we're going to treat this because we believe this is the best thing to do. So now let's go away from that, new patient, and you got a patient that's on their prostaglandin. They're doing pretty good. It's a bit annoying, whatever. Their eyes are a little bit dry. Their pressure was 24, now it's 17. Justin, what are you doing with that patient? If it ain't broke, don't fix it. Offering them an SLT. What are you doing?
Yeah, I mean, I said earlier with your question at the beginning, I care a lot more about the ocular surface. And so I'm actively talking to patients about it all the time. And so I'm 100% going to recommend, hey, your cornea looks crummy. You're taking the drop, your pressure's controlled, your glaucoma's controlled, but we have a great option where I can probably get you off that drop, make your ocular surface a lot better. Let's do SLT. So 100% we'll talk to them about that and very likely recommend it now.
Okay, so follow-up question to the earlier one. You tell 100% of first-time patients they should do SLT. How many of them actually do?
To Spencer's point, not as many as I would like. I would tell you still probably we're not 50-50. I mean, there's more doing drops than there are doing SLT. And is that more on me as the educator? Possibly. Maybe I need to be more along the lines of saying you need to do it. Or is it more just patient awareness around something like a laser, the way that we're promoting it? But I would say it's probably 30 to 40% are doing SLT, and it's still probably 60 to 70% are doing drops.
Yeah, okay. And that's probably better than we were at 4 years ago.
I would agree with you. Yes, definitely.
Yeah, I think so too. And I would verify those numbers. Now, with that person that's on a prostaglandin that has a little bit of dryness taking the drops, and you have this conversation, what do you think what percentage of them end up going to SLT or saying, now I'll just stick with the drop?
It does matter, I think, with symptomology for a lot of those patients. If they're not symptomatic, they're going to really say, I'm okay. I mean, if there's a cost factor and they're symptomatic, it's a high percent. I would say, 85 to 90% will move if they're symptomatic and the cost of the drop is a hindrance to them. Say it's a low percentage if they have no symptoms, no problems, and cost isn't a hindrance.
Lori, what are you doing with that mild glaucoma patient that's on a drop?
I'll admit I have a little advantage because oftentimes they're referred to me for intervention, so I have to acknowledge that. But I've changed my language around it to saying that new data is available in the last 5 years, and it shows that laser is actually better than drops. I say better. And I say, I don't want you to have to take this drop for the rest of your life. It's what I would want for my own eyes. And I would recommend this laser. And so I've changed from offering it kind of equivalent, saying as good as drops. I don't say that anymore. I say it's better. It's what I would want for my own eyes. Things have changed. I add historical context so patients understand that it's not like they were getting the wrong treatment or now suddenly we're trying to sell something to them. And I have really good luck with that. It's always hard to rock the boat when it seems that nothing's going wrong. But that is one of those things where it's like, don't wait till something goes wrong because then you've lost RNFL. So I have pretty good success with that. I'd say almost all patients that I push SLT for adopt it, and I feel guilty when they don't. Actually, I feel like it's a failure on my part to convey things properly. So I really say I prefer laser as treatment here in my clinic. And then if they really just look completely turned off, then I feel like I failed them, and then we have to concede and do a drop. But I try to still send them out with a handout and tell them to try the drop. Call me if it's hard to remember or whatever. But I think it's just really how you present it.
Let's talk more about your failure. So, what percentage of your naive patients, I know that that's not as common for you as a deep glaucoma specialist, but what percentage do you fail on and they end up with drops for the first-time treatments?
Yeah, I think naive is actually easier to convert.
Okay.
I'd say over 90%. You
Okay,
know,
great. And
you
then
can look
that
and see
patient,
how much I prescribe drops, and it's rare.
I appreciate the offer for verifying, but I have never heard you
Fact
say
checking.
anything other than the truth. And you have my unequivocal trust in everything that you say. The second question I would have is, what about that prostaglandin patient that it's a little bit of a pain in the butt, but it's not really causing a real problem right now? What percentage of those do you fail on?
Again, I have selection bias, but I'd say maybe 20%.
Yeah, okay.
It's rare. It's just rare in the way, and I've just changed, like you talking about evolution. I've just changed how I talk about it.
I think that it's I believe those numbers from you for sure. And I bet it's less the words you choose and more the confidence that you convey. We can sense when somebody is convicted on the right thing, and the words that you use go into it. But I don't think it matters if you say laser or light or all of those kind of shifty things, at least in my opinion, that seem a little bit, like disingenuous. It's whether or not I trust this person. They seem like they know what they're talking about, and they're giving me clear direction on what to do.
I want to add to that. I think, and you mentioned trust. So to see a doctor for one time, which they often are when they come in to meet us at Vance Thompson Vision, maybe their first visit with us, we're recommending an intervention. If they have a new diagnosis, it's hard. It's a lot all at once. And so you do have to have this patient trust you within one visit to make a treatment decision. And that's a big thing. And so it is so helpful and so crucial when they come in from their referring doctor expecting at least some sort of intervention. Like have some idea why they're coming to us. And like I said, I have a selection bias because a lot of our referring docs do that, and it's so helpful when patients have some sort of time to process that we're at least going to make a recommendation like that. And I just wanted to bring that up because this is obviously a collaborative process.
Yeah, I totally agree. And now, real quick around the horn, then we're going to go a little deeper in the algorithm past SLT. But new patient just got diagnosed with glaucoma. Use very few words. What's your one pearl you want to make sure that patient knows? Spencer.
The importance of the disease and treating it early.
Okay. Justin?
That we have great treatment options and we're not going to let you go blind.
Lori?
Similar. We are just scratching the surface and taking care of your disease, and we can't make it go away. But if you follow along with us, the chances of you going blind are very low.
Okay, great. Yeah,
John,
minus, go ahead.
Can I take one step back? I don't want to move past. There's one other part of the last conversation I just wanted to add a piece to, of the, patient comes in on one prostaglandin, they're doing pretty well, that you don't want to rock the boat a ton. But I think that the other thing that we didn't touch on that I do talk to patients about is compliance. I don't sit there and say, I know you're not taking your drop, but I do bring up the fact that, even our best patients forget drops every now and then. And, as caretakers, we know that the studies show that people take their drops a lot less than we'd like them to. And I think ignoring that is a problem. And so I think that even when people are on a drop, we have to realize they for sure took it the day before they saw us. They for sure took it. I know that I floss my teeth every time before I see the dentist. And, so they're showing up through our doors as well controlled as they can possibly be. And so I do talk to patients too about, a laser is great because it also is one less thing you have to remember to do. And I touch on the compliance issue. Sorry, I interrupted you before your thought.
Nope, that's great. And so last point here is there's a new SLT available, direct SLT. Lori, I know you got it. We've got it in Sioux Falls. And Do you think that this is going to move the adoption needle at all? Is it just easier because it's easier for us and easier for patients, but it's not really going to drive more patients to get it?
I think that any buzz or excitement about new technology is going to move the needle. And the more patients you can get in for this laser, the more word is going to spread. So whether they're getting in for DSLT or manual SLT is what a lot of people are calling it. I think DSLT does lower the barrier to entry or kind of bust down some of those fears patients have with, it's faster, nothing actually touches the eye. It certainly streamlines the clinic flow a bit, at least it has for me. So anything we can do on the doctor clinic side and also on the patient side to reduce these barriers, I think will help.
Okay, Justin, real quick, 20 seconds on DSLT.
Yeah, I think it will. I think we'll see a higher adoption rate. And the main reason is all our whole organization, we serve fairly rural areas where patients are traveling an extended distance. And, it's just nice to be able to tell a patient when they're sitting in the chair that, hey, we have a treatment option. We probably can do it today for you. It's efficient, it's quick. Our staff isn't going to be burdened by doing it. So I think all those things kind of come into place. So it's a customer experience piece, but also we're going to be able to treat a lot more patients because of the convenience around what it's going to do for our staff and us as the doctors too.
Yeah, good. I think to me it boils down to if you can make the right thing to do, the easy thing to do, it's more likely you're going to do the right thing. And so removing those barriers is important. Okay, so we did an SLT on somebody and their pressure didn't respond. Maybe they're in that 30% or so that didn't get it where we needed to go. They need additional therapy. Pretty easy if they've got a cataract. We're going to take that cataract out. And I bet 100% of the time we're doing a MIGS procedure. In that scenario where they've got cataract surgery, having cataract surgery and need a MIGS, mild glaucoma, what's your go-to and why in about 30 seconds? Spencer, what's your go-to MIGS?
I would say I'm between iStent and KDB goniotomy for a mild to moderate patient. I believe in both of them. And I tell patients the options and I say, one leaves something in the eye, has really good data long-term. One doesn't. And if either one of those sounds better to you, I feel comfortable doing either one of them. And I think either one will work.
Justin.
Lean towards stents in those situations, really just trying to have the mindset of what can I preserve long-term for my surgeon, to be able to do down the road when we need something additional. So that's kind of my mindset around it.
Do you give them options of the MIGS or not give them options of the MIGS?
I typically don't. I just tell them, hey, we're going to, I believe this patient you said had cataracts. I say, we're going to remove your cataract, we're going to put a couple stents in. This isn't a forever fix. This is a treatment along the journey, but we have other options down the road that we're going to be able to utilize. And we can utilize those options around these stents. We can remove them if we need to, but we have plenty of other options down the road in your glaucoma journey available if needed.
Lori?
I will do a TM stent, tissue sparing.
Yeah.
Leave that intact.
Got it. Okay, so that's pretty easy. We're going to do a MIGS procedure with a cataract surgery. Now you've got somebody that's pseudophakic. They've had an SLT. They're getting worse. They're not on a medication at all. What are you doing next? Reverse order. Lori, I'm your patient and my pressure is 22. I've got a little bit of damage, a little bit on my visual field, and I'm 70 and I've had cataract surgery already. And I'm going to believe whatever you tell me to do. What are you going to tell me to do?
I'm going to tell you to go stand at my DSLT and I'm going to look into those baby blue eyes for 2 seconds.
And you're going to do...
I'd repeat your SLT. Yeah.
Okay. Yeah, that's right. Great. I love it. Okay. So we're going to assume that we'll all repeat the SLT. So good. And Lori, my baby blues are just a little faded now because I'm so sad that second SLT didn't get us to our goal. Mm-hmm. What should I do?
I think I'd have a discussion with you, remind you of my treatment pattern of trying to avoid eye drops And usually the patients are like, understand why we want to do that. And then I'd probably talk to you about drug delivery. Although we'd have to talk about those baby blues, maybe turning hazel. So we talk about that, and then if you weren't keen on, keen on that, we could talk about a standalone MIGS. But I think when you are deciding to go into the eye surgically, you need to look at the visual field and make sure it warrants that risk. If you had a perfect visual field and only mild OCT changes, we might still try drops at that point, in my opinion.
Okay, so thank you for all of those options. I'm a little confused by it, but I trust you. What should I do?
Let's do a drug delivery.
Okay, which one?
I'd start with Durista.
Durista, and then if it works,
And
but
you like
only
it?
lasts 4 months?
Yep, we have good luck. It works. Then we can do an eye dose.
Great. Justin?
Yeah, I completely agree with Lori on drug delivery behind the slit lamp. So Durista, very good chance we're going to get what we need out of that. It's another treatment along the journey. We're going to add things later. We can stay out of the eye essentially, not in the OR, especially in a mild patient. So I don't have a lot to add. I agree with Lori on that one.
Spencer?
Yeah, I like it better when Lori goes first because we all just say, yeah, I agree. That's great. No, I think I agree completely. I would probably start with a Durista in this case. If it worked well and started to have a waning effect, would go to an eye dose. I also, I love what Justin said when we were talking about MIGS. I think even with something like a Durista or an implantable drug, it's important that patients understand, hey, this is not a fix for your glaucoma. You are not cured from your glaucoma because you've had a procedure or because you had a cataract surgery where we also addressed your glaucoma at the same time. Because I think patient understanding is very important and keeps their vigilance up with their disease process moving forward.
Okay, good. And I think that that's a totally reasonable algorithm. I might, and I probably would end up doing maybe 60% of those patients with some sort of MIGS procedure and maybe 40% with a drug delivery. I bet the drug delivery works a little bit better in terms of lowering IOP, but the MIGS works longer in terms of duration. And so my personal protocol on that is probably evolving a little bit. And I didn't say it just to provide some pushback to Lori. I actually think that that's where my practice pattern would be. So guys, we've only got 5 minutes left. Let's talk about
Wait,
new
which
technology.
MIGS, John? Which MIGS?
Yeah, so the challenge in standalone mild to moderate is you're kind of limited insurance wise. We're allowed to do whatever we want to do. It's just that insurance may choose not to cover it. And so it would probably be a goniotomy. And maybe if I'm doing just a goniotomy and a pseudophakic, I almost always add ECP. So maybe it's a nominee ECP, maybe it's a KDB goniotomy ECP, but that's probably what I'm doing. I wish that we could go with a stent because this is a pretty mild version. And I think that that is the least invasive. Okay, we've got 4 minutes left or so. Let's talk about how glaucoma is going to change in the next 5 years, new technologies that are either recently approved or coming to prove, so or coming forward. So, Lori, let's start with you again. How does glaucoma change in the next 5 years?
Hopefully we're seeing less and less severe disease as we adopt more of these newer interventions. I think we're going to see the supraciliary space come back on the scene. That's exciting. And then I have to say this because you're here, John, but I think we're going to see some novel, non-surgical, non-drop options for our patients. So maybe you could expand on that. But those are, I'll leave some other stuff for everybody else.
Okay, Justin?
Yeah, I think that, the narrative around SLT will need to continue to be discussed. So that's going to have to continue to be talked about. Drug delivery there's going to be more coming to the market. So we're going to have an array of those that we're going to have to try to figure out where do we utilize them, efficacy, how long, and then, moving into the MIGS space, we have femtosecond technology coming. There's different MIGS procedures that seem to be and could be less invasive even than what we have now, which is hard to believe because they're pretty non-invasive at this point in time. And I agree with Lori. I think having something like a set of goggles for the toughest glaucoma to treat, which you're pretty dang close to, John, is definitely an advantage for us as well for those types of patients.
Spencer?
Yeah, I agree. I think the best way we can be helpful is things that are effective that are as little symptomatic as possible for patients. So again, a plug for goggles, I think would be a really good way to treat people without medicine or surgery. And then I kind of also agree with the other two good docs here. I think drug delivery is going to continue to make advancements with, needing fewer and fewer dosages. And I also hope this supraciliary space, shows some promise too.
Great. So I think that I agree with all of that. We were having a conversation last night with some high test folks, and one of the things that came up is the leading cause of blindness around the world is cataract surgery. We got a permanent solution to that takes 7 minutes, and it's still the leading cause of blindness worldwide. Why? Because we can't find a way to deliver care to the people that need it. The second leading cause of blindness is glaucoma. That is partially a delivery of care issue, but largely we don't fundamentally understand what this disease is. My hope is in the next 5 to 10, we've got a better fundamental understanding of the disease, because kind of like what Yogi Berra said, if you don't know where you're going, you're not going to get there. So that's my hope for the biggest advancement that we make in the next 5 to 10 years. More pragmatically, improvements upon all the things that we have. And one thing that is actually different than everybody else, kind of like Sesame Street back in the day, one of these kids is doing their own thing, one is not like the other. And that is something that I have a lot of bias to, and probably all of you guys do too, a little bit, because you're involved in rooting for us. But that's the physics ocular pressure adjusting pump, which is a pair of goggles attached to a pump that releases the weight of the atmosphere, and we can dial in the eye pressure to whatever we want it to be. People wear it at night. It works while they're sleeping at night. When eye pressure has a tendency to go up, blood pressure goes down, and it's a vulnerable period. And it's not broadly commercially available yet. It is FDA approved, and we're working on getting Medicare reimbursement now so that it can be more broadly available. And it really is intended for some of our most difficult to treat patients. I think that we all want to avoid trabeculectomies, tube shunts, Zens, if we can in our patients, because we wouldn't want it in our own eye unless we had to have it because the benefits of these difficult procedures outweighed the risks because our glaucoma was so bad. And so with that, I'll give a final word around the horn. Spencer, final word?
Thanks for having me. This was fun. I always love sharing a space with people that, as you said, are experts in the field. I really thought you were going to say we wouldn't want a tube or a shunt in our eye unless Lori was doing it. And I was going to say, yeah, that's I agree with that as well.
Very good. Justin?
Yeah, great time with you guys. Just encouraging everyone that's listening to continue to stay proactive in the treatment of glaucoma, educate on the new options that are available. It's really an exciting time in treating patients with glaucoma right now.
Lori?
Yeah, I agree with Justin. We can talk all we want about these things, but if we don't get the patients in the door and have a chance to touch base with them on these things, then it's really kind of pointless. So collaborating with our network is so important, and we just appreciate the interest and the trust and the referrals.
Yeah, and I'll end with this. We are entrusted with the most precious sense, and we talked about the second leading cause of blindness today. And if not us, then who is going to continue to pull the profession, the patients, our communities forward to getting better levels of care? And this was our little attempt over the last 30 minutes or so to try and pull a couple more inches in that direction. Thank you, everybody. Really, really appreciate you guys.
Thanks, John.
Thanks, guys.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.